Good afternoon, everyone. This hearing for the Subcommittee on Africa, Global Health, Global Human Rights, and International Organizations will come to order. The subcommittee is meeting today to hear testimony on eradicating Ebola, building on lessons learned and medical advancements. I want to thank everyone, including our witnesses, for your patience. We had a series of votes, and other members will be joining us shortly, but we are joined by our ranking member, Mr. Smith. So today we're here to discuss the eradication of Ebola and some of the medical advancements and lessons learned in trying to suppress this deadly disease. Ebola is one of the deadliest viral diseases in the world and has become a part of the global health landscape. The recent discovery of an Ebola vaccine and better healthcare employee training have helped improve response times to outbreaks and decrease the ability of the virus transmitting to remote areas. However, Ebola outbreaks are often complicated by regional conflict, lack of trust between local communities and practitioners, and armed groups attacking and burning down treatment centers. This hearing will address the challenges and opportunities to combat the transmission of Ebola and the effort and collaboration needed by appropriate stakeholders. I look forward to hearing more from our witnesses regarding the Ebola vaccines and how they are being used in this most recent outbreak. So without objection, all members may have 5 days to submit statements, questions, extraneous materials for the record, subject to the length limitation in the rules. I recognize myself for the purpose of making an opening statement. I would also like to thank our distinguished witnesses who are here with us today. The current outbreak in the Democratic Republic of the Congo began in August of last year and is the second largest to date, and as of news reporting from today, may have reached up to over 2,000 cases and almost 1,200 confirmed deaths. If we don't collaborate with all stakeholders to combat the outbreak and ultimately eradicate Ebola, the disease would surpass the 2014-2016 outbreak, the deadliest in history, which had 11,000 recorded deaths and 28,000 total cases. That outbreak started in Guinea, Liberia, and Sierra Leone, then spread to Mali, Nigeria, and Senegal, and even beyond the continent, with cases in Italy, Spain, the United Kingdom, and I think we all remember the cases in the United States. The Ebola epidemic has been heightened because it is in a conflict zone in the Democratic Republic of the Congo. The epicenter of the outbreak is in North Kivu, which happens to have more than 100 active armed groups in the region. North Kivu also shares a border with Uganda and is a hub for travel and trade, but also various other types of movement across the border. New cases are hard to determine because the violence and political unrest in the affected areas have further restricted the community's access to health care. The lack of security in the region is also hindering the Ebola response by making it difficult to trace contacts and organize crucial community outreach activities. Some health centers have been temporarily closed or damaged. Several of the health workers have been killed. I know that the people of the DRC are frustrated because of the lack of medicine, food, and foreign companies extracting the country's precious minerals, but that is no excuse to burn down facilities or attack or kill people that are there to help treat this deadly disease. What this indicates, though, is that we must work to do all that we can to keep these health practitioners safe. This means that we have to think beyond just providing humanitarian assistance for medical treatment. USAID Administrator Mark Green said in testimony before the Senate 2 weeks earlier that when it comes to Ebola, the DRC setting is a labyrinth of challenges, poor governance, resentment toward community leaders. With a failed democracy in many, many ways, it will take more than simply a medical approach. Considering the dilemma of suppressing this outbreak, I look forward to hearing your views and suggestions in your testimony or in the Q&A. I'm also very interested in hearing the pros and cons of identifying this outbreak as an international public health emergency. Why wouldn't we declare that? Those are just a few concerns I want to pose to the witnesses. Finally, I'm concerned that the administration released a presidential memo last November implementing aid restrictions to most of the Tier 3 countries found in the 2018 TIP report. It clearly states in Section 110, the President shall exercise the waiver authority when necessary to avoid significant adverse effects on vulnerable populations, including women and children. Not focusing resources on health, education, and community outreach hinders the success of countering the Ebola outbreak in the DRC, and I urge the administration to act more diligently now. This administration has an opportunity and an obligation to try and stop the deadly outbreak, and that's why we're having this hearing, and I'm introducing the Ebola Eradication Act of 2019, which would authorize USAID to assist with the Ebola efforts in the DRC. Lastly, I believe that it is imperative that we not let Ebola reach Goma, because if it does, it's highly probable that it will reach Rwanda, Uganda, Ethiopia, and South Sudan. Oh my goodness. And that would have an effect on humanitarian efforts, peace and security, and economic trade. So the Tier 3 status is something I know the ranking member is the author of the TIP report and has worked for many years on this, and it kind of presents a little bit of a dilemma where we certainly don't want to do anything to reward a country that's a Tier 3 status, but on the other hand, we have this situation where we have Ebola in a Tier 3 country. So what do you do? Not provide aid when this disease obviously has international impact. So I now want to recognize the ranking member for the purpose of making an opening statement.
Thank you very much, Madam Chair. Thank you for convening this very important and timely hearing. As she knows, the gentlelady from California, my good friend, and some of you may remember, this subcommittee was heavily engaged in the summer of 2014 in addressing Ebola when we were in the midst of an Ebola outbreak in Sierra Leone and in Liberia, and the ensuing panic over the disease. We actually held 3 hearings during a 4-month span, a period when many around the world thought a new equivalent of the bubonic plague was about to jump borders and overwhelm the health systems, especially of sub-Saharan Africa. Indeed, there was a period when we thought that Nigeria, particularly in Lagos, Nigeria is the most populous country in Africa, would suffer from a pandemic outbreak. But thanks to a largely unheralded work of a number of key actors, including and especially our own Centers for Disease Control, the outbreak was contained. And while we did have cases in the U.S. due to highly effective quarantine measures and state-of-the-art medical care, we were able to dodge that bullet as well. Perhaps our witnesses, Dr. Robert Redfield, can enlighten us further as to the critical role the CDC played with regard to global efforts in containing and then defeating the 2014 Ebola outbreak, particularly in Nigeria, and lessons that have been learned. Although in many ways today we are better equipped to address Ebola outbreaks, certainly in terms of vaccines that were not readily available in 2014, as a practical boots-on-the-ground matter, we are in some ways worse off dealing with the current outbreak, which began in 2018. Last year's outbreak in the DRC has now spread in populated areas of the eastern DRC. What makes the situation more difficult this time is the security situation, with vicious attacks on healthcare workers. As reported by the Washington Post, according to the WHO, there have been some 119 attacks against health workers this year, and that was as of May, with some 85 wounded or killed. The presence of expatriates, in particular, among the healthcare workers appears to have increased the militants who have carried out the attacks. When one considers that these dedicated health workers put their lives on the line to help prevent and treat Ebola, the fact that they should be targeted boggles the mind. Recall the testimony of Dr. Kent Brantley at one of our 2014 hearings, how he contracted the disease despite taking every precaution while helping Ebola patients in Liberia. We hope to get an update from our witnesses today as to what is the security situation on the ground and whether we are putting our CDC and other personnel further in harm's way beyond the threat posed by the Ebola virus. Finally, I would like to address the issue, and it was just raised by my good friend and colleague, Chairwoman Bass. There is some concern that assistance to the DR Congo used to combat Ebola will be cut based on the fact that our State Department has designated the DRC as a Tier 3 country in terms of human trafficking. I certainly hope that this is not the case, as it does not comport with the intent behind the legislation. As the author of the Trafficking Victims Protection Act of 2000, the TPVA requires that we withhold non-humanitarian, non-trade-related foreign assistance to the government of Tier 3 countries, which means that the country does not fully comply with the minimum standards and are not making significant efforts to do so. I note that the TVPA explicitly excludes humanitarian and trade-related assistance from any assistance cutoff. It further allows development assistance which directly addresses basic human needs, which is not administered by the government. In other words, development assistance can flow via non-state entities or non-government organizations, including faith-based actors. Indeed, if one visits the Eastern DRC, and I visited myself, one notices that health and education needs are met largely by faith-based entities, as the government and its institutions are viewed with a great deal of suspicion. Moreover, Section 110(d)(4) of the TVPA vests the President with waiver authority with respect to non-humanitarian, non-trade-related foreign assistance, when such assistance is in the national interest of the United States, such as in the prevention of the spread of Ebola. Further, the TVPA mandates that the President exercise such waiver authority, quote, when necessary to avoid significant adverse effects on vulnerable populations, including women and children. If there is any misunderstanding with respect to how this law should be interpreted or implemented, I know that the chairwoman and I would be very happy to meet with leaders of the administration to discuss that. I do want to note that since fiscal year 2018, the American taxpayers have provided approximately $330 million in humanitarian assistance to the Democratic Republic of Congo and some $87 million in response to the Ebola crisis. I'm further told that additional congressional notifications for the DRC will be forthcoming, and look forward to receiving and reviewing those as well. Thank you, Madam Chair, and I yield back.
Thank you very much. And before I introduce the witnesses, I would just like to acknowledge a few people who are in the audience. This is a special day on the Hill when we acknowledge, celebrate, and lift up the hundreds of thousands of young people who are in the nation's child welfare system. And so for the first time, I've been doing this for years, but for the first time, 3 of our former foster youth are from the continent of Africa. One is from the Democratic Republic of the Congo, Ethiopia, and Kenya. And so I want to acknowledge them for being here. Raise your hands or stand up. Yes, thank you. And in support of the young people is a very famous actor who is represents one of my favorite TV shows, Blackish, Marcus Scribner, who is here with his father, who is here supporting all of the foster youth. So thank you very much for attending. And now to our panel. Admiral Ziemer is the Acting Assistant Administrator for the Bureau of Democracy, Conflict, and Humanitarian Assistance at USAID. From April 2017 to July 2018, he was appointed by President Trump to be the Senior Director for Global Health Security and Biodefense at the National Security Council. And in June 2006, he was nominated by President Bush to lead the President's Malaria Initiative. Dr. Robert Redfield is the Director for the Center for Disease Control and Prevention. He has been a public health leader actively engaged in clinical research and clinical care of chronic human viral infections and infectious diseases, especially HIV, for more than 30 years. He made several important early contributions to the scientific understanding of HIV, and in addition to his research, he oversees an extensive clinical program providing HIV care and treatment in the Baltimore, Washington, D.C. community. Thank you very much today, and please, we would like to hear a summary of your testimony. We have your written testimony, but if you would present for 5 minutes, and then we will have questions and answers by the panelists.
Chair Bass, Ranking Member Smith, members of the subcommittee, thank you for the opportunity to speak with you today about the United States government's response to the ongoing Ebola outbreak. Chair, you referenced the 2014 West Africa outbreak and the devastation and the impact that it had. The current outbreak in North Kivu and in Ituri province has just surpassed 2,020 cases. The situation is worsening, and the numbers of cases will continue to rise. Last month, I traveled to Eastern DRC with a core team from Usaid and CDC. I met with health teams, local community leaders, our implementing partners, and saw firsthand the scale and complexity of this outbreak. I've traveled extensively in my career, for my 3 decades in the U.S. Navy and in the roles that I've had since. This trip to the DRC was one of the most sobering trips I've ever taken. The scope of this biosecurity threat is changing, and the risk of the virus leaping the border to other countries is very high. This will further destabilize the region economically and heighten insecurity. In order to control this Ebola outbreak, at its source, a fundamental shift and an immediate reset is necessary. The ongoing violence and community distrust towards the response has been summarized by both of the opening statements. Armed group violence, as well as deep-rooted community resistance, has really kept the health teams from doing their critical health savings work and frequently results in the suspension of the response efforts. In February, community members set fire and destroyed the Katwa Ebola treatment unit. When I was there, we saw it restored. The evening we left, one of the guards was killed in another recurring attack. There have been over 70 security incidents this year alone. Cases have been accelerating in areas where the community members exhibit deep-rooted distrust of the central government and foreigners, as well as the people from other regions within DRC. This widespread distrust has fueled misconceptions about the disease and deep suspicion regarding the motives of this sudden and dramatic international presence responding to Ebola. And as well, it's the feelings of the community that they're being exploited by this inject of cash. They referred to it as the Ebola economy. There's clear consensus among the stakeholders that we need to listen better to the communities, listen to what they are feeling, and that should and must inform the trajectory of how we can shift this accelerated increase in cases. The outbreak is not just a public health crisis. It's an outbreak in the midst of a complex emergency. In order to contain this outbreak, a broader, more holistic humanitarian approach is needed. Towards this end, Usaid, supported by CDC as the technical lead, is leading a whole-of-government response focusing on 6 key areas in order to bring this Ebola outbreak to an end. Let me just quickly review those 6 areas of focus. First, we're working to improve coordination among the DRC government, WHO, and our international partners. I'm pleased to say that over the last week to 10 days, significant change is underway to accomplish that objective. Secondly, we are emphasizing and addressing the paramount importance of community engagement and local ownership. Third, we are working with the newly appointed UN Ebola Response Coordinator, Mr. David Gressley, to bolster security coordination through non-militarized humanitarian approaches. And fourth, we're working with CDC to implement operational improvements in the public health response, including a forward-leaning vaccine strategy. Fifth, we're looking at the Ebola readiness in Goma and along the Goma-Bentembo corridor, as well as the 4 countries to the east. And lastly, we're engaged in a longer-term planning scenario for stabilization and development to address the root causes of fragility in the region. This reset is building on the work of our USAID-funded partners that have been implementing key aspects of this public health response. Our partners have helped train 1,680 community health workers to conduct surveillance, strengthen infection prevention control measures in over 280 health facilities, reached 1.5 million people with health messages, and provided enough food to meet the needs of approximately 45,000 beneficiaries each month, and much more. There is no silver bullet to end this outbreak, but I believe that an adaptable whole-of-government response that capitalizes upon each agency's unique strengths and expertise will be successful in containing, controlling, and ultimately ending this outbreak. I look forward to your questions.
Dr. Redfield.
Good afternoon, Chair Bass, Ranking Member Smith, and members of the subcommittee. Thank you for the opportunity to update you on the Ebola outbreak in the DRC and outline what CDC is doing to prevent, detect, and respond to this and other emerging global health threats. CDC's efforts are grounded in over 40 years of Ebola research and more than 20 Ebola outbreak responses. I want to emphasize that our goal is to end this outbreak as soon as possible. When I visited Beni 2 weeks after the outbreak was declared last August, I saw firsthand the complexity of this urban Ebola outbreak. In March, I traveled back again to the outbreak zone where I met with responders on the front lines. These trips further reinforced my understanding of the critical role that experienced technical leadership plays in the field. This is the first urban outbreak in the DRC, occurring in densely populated areas that have experienced decades of conflict and civil unrest, which continue today. The two currently affected provinces have never experienced an Ebola outbreak. They have busy, porous borders with Uganda, Rwanda, and South Sudan. These challenges make this outbreak extremely difficult. As of this week, we have surpassed the grim milestone with now 2,020 cases, 1,354 deaths occurring in 22 health zones. A significant percentage of these cases have actually been acquired in healthcare settings, including 109 healthcare workers. In the past 42 days, we've seen 668 active cases in 18 different health zones. Of these cases, less than a quarter were known contacts and monitored. Even more concerning, roughly 40% were community deaths that occurred outside the healthcare system. Based on experience from previous outbreaks, an effective response demands early ascertainment and effective isolation of at least 70% of all cases and sustaining this for several months. The fact that we are seeing so many community deaths means that we are missing contacts. While no Ebola cases have been confirmed outside the DRC, this outbreak is not under control at this time. CDC is working with the World Health Organization to support vaccination. Over 130,000 people in the DRC and surrounding countries have been vaccinated to date. Recently, WHO has recommended the expansion of vaccination strategies and an increase in vaccine supply to reach a greater number of individuals at risk for Ebola. Over the course of this outbreak, CDC has deployed 184 experts to the DRC, neighboring countries, and the World Health Organization headquarters. Our work includes case recognition and contact tracing, infection control in the healthcare settings, safe burials, laboratory testing, border health, vaccination, and real-time data analysis to inform the response. CDC also continues to provide direct assistance to the DRC Ministry of Health, both in Kinshasa and Goma, where the Incident Command is now located, the World Health Organization in Geneva, and the United States government response in the DRC, while also enhancing preparedness efforts in the neighboring countries. While this outbreak continues to be an urgent situation in the region, the current risk to America is low. The most effective way to protect America from emerging threats is to stop disease at their source, before they reach our borders. We've seen tremendous progress in the rapid disease detection and response. For example, this includes meningitis in Liberia, multi-drug-resistant tuberculosis in India, and the rapid detection of yellow fever in Uganda, all a direct result of CDC's global health security investment. CDC continues to improve the technical public health workforce abroad. We've trained over 12,000 public health professionals, now in 70 countries. More than 200 of these CDC-trained professionals are currently in the DRC. CDC continues to position our assets globally to quickly respond to the emerging health threats and disease hotspots. Finally, I want to thank you for your continued commitment and support to CDC and our critical global health security mission. Thank you.
Thank you very much. You know, I wanted to know if you could elaborate and explain a little bit about the differences in how people are responding to the epidemic. Like, you remember when it started in Liberia and Guinea, there were challenges over traditional practices of how you deal with the dead. And that was one of the reasons why the outbreak was spreading, because, you know, it took a while to get people to break with their traditional practices of washing and preparing the body. Here in the DRC, you have the conflict where the workers are being attacked, and it's believed as though the disease is fake. And I just want to know if you can elaborate a little more on what is going on. Why on earth would people be attacking the facilities and the healthcare workers? And then I don't know if any of this is involved in the broader political situation in terms of the election that happened. The new president was here. He came and we met with him. What was Mr. Smith? It was maybe a couple of months ago that he was here. And I was surprised because when he was here, he requested essentially security assistance. And I understand that there's security problems, but in the midst of an epidemic like this, I was surprised by that request. So could you please explain your perspectives on why are the attacks happening? Why don't people understand that this is a real deadly disease?
I think that is the question.
Microphone's not on.
Oh.
How about now?
There, okay. I think your question is exactly the question that we're trying to filter through. If you look at the three vectors, the virus, the security situation, and the community lack of cooperation, all three of those are going in the wrong direction. Okay? We know how to control the virus. We just can't get there and do what's needed in order to bring this under control based on the previous experiences. The last outbreak was in the Equator province, and with the DRC's response complemented by CDC, it was brought to close. So what's different in this region that would cause this deep-rooted response in the negative? Human behavior is driven by many.
But I mean, you know, I know that there's a lot of armed groups. I don't know if the armed groups are ideologically based, if they're ethnically based, if they, you know.
Yeah, there are over 60 to 70 armed groups with different motivations and different intent. They have undermined the community's intents and welfare over the years. My father knew a colleague who was killed in 1964, Dr. Paul Carlson, not too far from this area. There has been deep-rooted issues having to do with insecurity and lack of insecurity.
How is the new administration responding? How is the new administration in the DRC?
You mean
The
President?
new president,
Based on the feedback we're getting, President Tshisekedi represents a bright light. He has visited the area, is something that his predecessor never did. We are hopeful that with that type of political support, with the efforts by the partners and the local responders, that there might be an opportunity to start seeing a change in the receptivity of the community.
In terms of the waiver that our administration needs to provide, has that happened, or are you under the belief that we have to hold back aid because of their involvement in human trafficking?
Yeah, well, DRC has certainly been impacted by the TVPA restrictions, and we need to use all the tools.
Do you get a sense from the Trump administration that they're going to give a waiver to allow you to use all the tools you have?
Chair, we're waiting to hear that. I would like to offer, though, that the current investment by Usaid in this response has been unimpeded. We are using IDA money from the 2015 appropriation to invest and respond to this outbreak.
Okay, thank you. Mr. Ranking Member?
Thank you very much, Madam Chair. If I could, one of the ways that the message got out during the crisis of Ebola in Sierra Leone and Liberia was with cell phones. And I'm wondering, and I know we have an effort, I saw it in your testimony, Dr. Redford, of getting that information out to key personnel. Is there, generally speaking, an effort to get it to the public? Because apparently that was one way of getting that message out about how to keep yourself from getting contaminated. Secondly, or sick, what kind of security arrangements are being made for health workers? Is the president, for example, not ours, of course, I'm talking about the president of DRC, mustering a group of perhaps his best of the best to make sure that that situation, the risk to the workers and to the people, of course, is mitigated? If you could get to that as well. I do have other questions, but you said 130,000 have been vaccinated to date, and I wonder if you could just enlighten us, elaborate on whether the vaccination, how long when somebody gets it before protection kicks in? Is there enough vaccine available? Has anybody, including healthcare workers, gotten the disease after vaccination? How efficacious is it? Is it 100%, 90%? And then if you could speak to the faith community. Obviously, there are many, and when I've been there, met with a lot of the church leaders. They do wonderful work, but I'm wondering if they're being fully brought into, the messaging and the protection strategy. You talked about train the trainers in your testimony, Dr. Redford. Maybe you could elaborate a little bit on that as well. I think that's an excellent concept. Thank you for doing it, but maybe you could tell us a little more what you are doing. And finally, and I do have other questions, but what tools are not available in the toolbox that the Trafficking Victims Protection Act sanctions is precluding? My sense is, and I have spoken to many, so far I don't know of any, but there may be, and I'm missing it. Again, that's where the waiver authority would come in to help meet this crisis head on. But I'm just wondering what isn't being done that would require an act of Congress or, again, a waiver by the President of the United States.
On the security front, I think it's clear that the entire two-province area is insecure. I think what we are looking forward to is a positive shift with the appointment of David Gressley as the deputy for the UN Ebola response. He is being moved over from the MINUSCA, where he was the deputy responsible for the security forces. And so his understanding of security in that area as a very experienced African hand will give us a significant insight into how better to improve the security. When I was there, I asked WHO what they needed most. They said security. When I asked the community workers what they needed most, they said less security. So somehow we have to get in there and understand the dynamics, what the security requirements are, and it's counterintuitive to move forward in an area where there's such variation in demand and how to move forward to provide the health care. Let me just jump into what tools are in the toolkit to offset the TVPA. I would just say at this point, it's clear that additional funding would complement the current outbreak response. It would be complementary, it would build capacity. Once we get a final ruling on that, we'll see where we stand and we'll press ahead.
I think I can start with maybe the vaccine questions. Clearly, this is a great addition to our toolbox to stop this outbreak, the vaccines. They're currently both unlicensed vaccines. The one that's currently being used is the Merck Sharp and Dohme vaccine. As you said, it's been to 130,000 individuals. The way it's being administered is if you identify a case, then you find the contacts around that case, and then you find the contacts around that case, and you try to immunize everybody. Operationally, this isn't really going as effectively as we'd like. If you look at cases that present and then ask the question, were they previously identified as a case, were they previously monitored, and were they previously vaccinated, currently it's less than 20%. Right? And as I mentioned in my testimony, we're not going to get anywhere near effective control until we get this over 70%. Vaccine supply is limited, and there's a need to accelerate that supply. Merck Sharp and Dohme is the current provider of it, and there is a need to increase that supply. There is an opportunity to do what we call split dosing to make the supply go further, which is currently being recommended, but we do need more vaccine for sure. Related to
Doctor, can you
efficacy,
say how much more? I mean, what is the unmet, how much more vaccine? How much are we lacking?
right now there's about 145,000 doses of vaccine. As I mentioned to you, if you realize that we're only vaccinating about 20% of the people that we want to be vaccinating right now, you can see that there's a need substantially for more vaccine. The other thing I would mention that the new strategy is going to go beyond vaccinating contacts and context of contacts. We now actually want to vaccinate geographic areas where we can't function because of the insecurity. Unfortunately, there's going to be a 6 to 12-month lag before there's adequate vaccine supply. So we do project that we are going to run out of vaccine before we get adequate vaccine. Sometime.
If I could briefly on the vaccine issue, is it safe? Are there downsides
it's,
to
again,
it?
it's a non-licensed.
How long of a shelf life is it?
Yeah, it's a non-licensed vaccine, but it should be licensed soon. The shelf life is fairly long, particularly in bulk. And clearly the shelf life, once it's vialed, is also very reasonable, multiple years. The truth is, not everybody that's been vaccinated, though, has been protected. There are breakthroughs. The estimated efficacy of the vaccine is, say, over 85%. But again, that's not through any controlled clinical trial. That's just back-of-the-envelope efficacy. So we do have cases in individuals that have been vaccinated. But it does, I think there's significant evidence that this vaccine is impacting acquisition substantially. And there's a suggestion, again, it's premature, data is ongoing, that if you do get vaccinated and you then do get infected, that your clinical course may be more ameliorated. But again, this is still in the absence of controlled data. This is just what appears to be the observation.
Thank you. Representative Wild?
Thank you, Madam Chairman. Good afternoon. Dr. Redfield, just following up on what you were just testifying about, what is split dosing? You made reference to split dosing.
So what that means is there's a normal dose that's currently administered, and rather than give a full dose, they're planning to give half a dose. Now, it turns out that half a dose has been shown in their NDA application to the FDA to give an adequate immune response. So the FDA has looked at that. They do believe that that's going to be efficacious. And it's similar to the dose. It's actually even more than the dose that was used in West Africa in some of the efficacy trials. So we do think there's substantial evidence that half of the dose is going to be effective.
And where is it being manufactured?
Right now, the initial lot was manufactured in West Point in a production plant by Merck Sharp and Dohme. That plant was closed, and they've moved the production facility to Germany. That production facility currently is going through what we call validation lots to make sure that it can make the product effectively. And one of the recent validation lots didn't validate, so that's another reason. So there are discussions about, our secretaries had discussions about what can be done to try to look at ways that Merck might be able to accelerate vaccine availability.
And how close are we to having this vaccine ready for license and broad administration, would you say?
My understanding from the FDA meetings that we've listened to their presentation that we're just waiting for the validation of the new plants. So in other words, the clinical efficacy data, safety data is there. It's just waiting to prove that the plant that's going to make the vaccine is validated to make it in a reliable way.
Okay. And I want to switch gears with you, Dr. Redfield. In your written testimony, you indicate that in the last calendar year, there were 1,954 reported cases and 1,314 deaths, which by my calculations is a 67% fatality rate. And you indicate that the number of cases is continuing to increase. I assume that accurate reporting of cases and tracing of contacts is essential. Is that fair to say?
To get control of the epidemic, for sure.
Okay. And one missed case or one missed opportunity to trace contacts can keep the outbreak going or cause it to spread. Fair enough, right?
Correct.
So my question to you is threefold. How accurate do you think those numbers are that are in your written testimony? I'll ask all the questions and then you can address it. How accurate do you think those numbers are? Is there some kind of uniform infrastructure through which we count and track these diagnoses? And are medical examiners or coroners reluctant to report the cause of death?
So first is we're confident that the numbers underrepresent the outbreak. I think first and foremost, I've tried to illustrate this late in the outbreak where you see up to 40% of the individuals presenting as community deaths. There was no way for us to do contacts of contacts. Those people stayed in the community until they died. Mm-hmm. The problem with Ebola is the infectivity goes up and up and up and up and up as you get sick towards death. And probably one of the most infectious ways to transmit HIV, as Chair mentioned in her comments, is through burial. And you wonder why we're seeing that this late in the game. Well, this region never experienced Ebola before. They don't understand Ebola. You know, how do we see this outbreak? 25% of the people that got Ebola got it because they were sick and went to a hospital with something else and then got infected with Ebola when they went to the hospital. So you argue we need infection control. In the last 21 days, we had 11 healthcare professionals come down with Ebola. So we still don't have effective infectious control. So this really underscores, as you mentioned, we're not anywhere near getting 95% of those contacts identified in cases and isolated. Okay. We're lucky to be 30%.
Okay, I want to move on to one other thing real quickly before my time runs out. Admiral Ziemer, in 2015, after the Ebola outbreak ended in West Africa, then President Obama created a special National Security Council team to oversee epidemic preparedness and response on a permanent basis. And my understanding is you were the official leading that team until the summer of 2018. Is that right? And does that global health, security, and biodefense team even still exist today?
Yes, it does. The office has changed at the NSC. The initiative is led by the State Department and supported by CDC and Usaid. So the mechanism, the strategy, and the commitment still exists.
And who leads it now?
It's led through the NSC, but the State Department is the interagency lead.
Thank you.
Representative Wright.
Thank you, Madam Chair, and thank you, gentlemen, for being here. As all of us know, Ebola and its potential for an international epidemic is very real for my home state of Texas and my home county of Tarrant County, which borders Dallas. Back in 2014, Thomas Eric Duncan died from Ebola in Dallas after traveling there from Liberia. All of you know that story. And two of the nurses who provided treatment, Nina Pham and Amber Vinson, in Dallas were later diagnosed with Ebola and, thank God, survived. Earlier in 2014, Dr. Kent Brantley, who completed his residency and fellowship in Fort Worth at John Peter Smith, our public hospital, contracted Ebola while serving as a medical missionary. You know that story as well. I got to visit with him in December of 2014. He's a remarkable man, remarkable doctor. So the point is, we in the Dallas-Fort Worth area know probably better than any community that what happens in the DRC, what happens overseas, can happen here, and it can happen very quickly. My question is, because when this happened back in 2014, it was like a bomb going off in the Dallas-Fort Worth area. My question is, what were the biggest lessons learned from that? And I'll go with Dr. Redfield first, that are benefiting us now.
Congressman, I think probably the most important lesson that we're operationalizing now is to really prepare, particularly the bordering countries. We've been very fortunate, if there is any fortunate in this outbreak, in that it's a very remote area without significant air travel, without significant roads. This is why, as was discussed already by the chair, if or when this outbreak extends to Goma, which is the place of an airport, this could offer greater challenge. Currently, we have really prepared South Sudan, Uganda, and Rwanda, and Goma area to be able to recognize these cases quickly, like we saw in Nigeria in the 2014 outbreak, and, if you will, shut them down so there's not a lot of secondary transmission. So this border screening is really important. I think many people will be shocked when I say this. In this outbreak to date, we've screened over 58 million people. And you say to yourself, wait a minute, how did we screen 58 million people and we don't have cross-border, cross-region transmission yet? You know, you can think about that. I think it's really remarkable, to say the least. But I do think that to really recognizing how important preparedness is and border screening is at the source. This comes back to my testimony for America. The best thing we can do is stop these epidemics at their source and to really focus on doing that. So I think that's the lesson I know we've all taken home. The preparedness is just not something to do casually. It's something to do very seriously.
All right. And Admiral, I had a follow-up for you. A while ago, you mentioned how people there feel exploited. Can you elaborate on that, exactly what that means? That they feel exploited by the Ebola economy, if you will?
Congressman, let me quote one of the community leaders that I interviewed. He said, for years we've been abandoned by our government. We haven't been cared for. We've seen people die of malaria, cholera. Thousands of people have been killed, and we've been left on our own. And now Ebola happens, and you show up. And so that point of communication spoke volumes to me. Ebola, to them, was more important to us than it was to them. We are there to contain it, to keep it from spreading, and we're rolling in with sophisticated interventions, committed people, and a significant amount of funding. And they feel as though they haven't benefited and that they are going to be abandoned as soon as the Ebola outbreak is contained. And that is the message that we have got to listen to and move and try to encapsulate as we look at this very unstable world that borders some fairly significant countries.
Great. Thank you very much. I'll yield back.
Representative Houlihan.
Thank you, Madam Chair. Thank you very much for coming today. I have a bit of a preamble before my question, so maybe a minute or so. Women and girls are the two groups that are disproportionately affected by this outbreak. Women and women's groups also have the capacity to advance response activities through socialization and education in their communities, yet little outreach seems to be being done to this critical group. According to a rapid assessment by the International Rescue Committee from March 2019, which is responding directly to this outbreak, pre-existing gender norms expose women and girls to specific and increased risks during disease outbreaks. And during the current outbreak of Ebola in North Kivu, in the DRC, health actors have seen a similar pattern to that they saw in West Africa in 2014, with infection rates for women and girls fluctuating between 57 and 62%. In addition, the IRC found that women and girls carry primary responsibility for caring for the sick and for managing household prevention, and this means that women and girls, and particularly adolescent girls, must increase the number of times they travel long distances by foot each day to fetch water. And this results in elevated risks of sexual violence and harassment. So here are my questions. Admiral Ziemer, what is being done to ensure that women and girls have access to services, both health but also sexual and gender-based violence related during this outbreak, if you can comment on that?
Thanks for the question. I can say clearly that the interventions and the treatment is focused for all. There clearly is a significant increase in children and women, and so that is being noted and factored into our interventions.
And so is there any sort of coordinated activity that specifically relates to the sexual violence of women and girls as it relates to their exposure to the Ebola, or as it relates to treating Ebola in that particular population? Is there any coordinated effort on that end that you're aware of? And should there be?
Yeah, there should be. I know our partners are looking at that specifically, and I'll get back to you with specifics on that.
That'd be wonderful. And my next question is for either of you gentlemen. What lessons did you each or your organizations learn from the West Africa outbreak, and how have they been applied to the DRC outbreak, and maybe specific to women and girls, if you're able to dive deeper into that?
I would say the lessons learned from West Africa are significant. The ability to take all of those lessons and apply them have been interrupted by the community resistance and the security reality. Okay, so unfortunately, we can't. There's not a direct benefit from that. Although we've learned a lot, the other significant tool that has been brought in is the vaccine. The situation would look a lot worse if it hadn't been for the vaccine that Dr. Redfield has just summarized. In terms of the program's lessons learned in dealing with women and girls in West Africa and the transfer into the current two provinces, again, I'll get back to you.
Thank you. I would really appreciate that. And are there any efforts to be being made right now to codify or to think about lessons learned as we learn them now in the field to be able to apply them in the future? Are we in the process of sort of having weekly conversations about what we have learned in this particular instance so that we can use them in the future?
Yes, I can commit to you that we'll make sure that that's ongoing.
And finally, what kind of cultural barriers to educating the impacted communities have you encountered, and how are you experiencing the opportunity to apply best practices to the Congolese people? I know that you've spoken a lot about the resistance, and I completely can empathize and understand the situation, but have we found anything that is working to be able to convey to particularly women and girls, you know, who are the caregivers and who are largely exposed to this, what lessons could be used to be able to make them safer?
Yeah, one of our primary partners is UNICEF, and I know they focus on that as a priority. We will follow up on that too, just to give you specifics on how UNICEF and our other partners are applying the ongoing lessons learned so that we improve upon that particular issue.
I really appreciate your efforts on this. This is something that literally keeps me up at night. Biology and the concerns that come out of Africa and Asia are something that are very, very concerning, I think, and should be for all of us. So thank you very much for your care. I yield back.
Mr. Burchett.
Thank you, ma'am. Was I being called down for talking, or was I being called on to speak?
Either.
All right. I'll go speak then. How about that? Thank you all for being here. How does the armed conflict that's currently ongoing in the center of the outbreak affect the chances of the disease spreading across the border? And are those that are involved in this conflict, do they understand about and are they concerned with the spread of the disease? Because a lot of times it seems like education is the key, and there's always seems to be a disconnect.
Yeah, my immediate response is the armed conflict is characterized by armed resistance with armed individuals to neighborhood gangs to basically the Mai, which are thugs on hire. Okay? And then we have community resistance that manifests itself in insecurity. All of that together is undermining our ability to do good health work. What are we doing about it? I think we are continuing to talk to the community, get the community involved in determining what their perspective is, their recommendations. But clearly, the security environment has been unstable. It continues to destabilize the approach, and it's one of the priorities that we are looking at.
Doctor.
The comment I wanted to make, I have a slide I'd like to just show you about what the impact of the armed conflict is. If she puts up the second slide. If you look at this second half of the slide, that red line, that's the current outbreak. All the lines you see before that, those are all the other outbreaks besides West Africa. The insecurity has caused a lack of our ability to bring this outbreak to an end. You can see that most of these outbreaks are over in 4 months. Right? This outbreak now is, if you go back to this time of initial symptoms, is really actually now over a year old, even though it was recognized in August, some of those symptoms. So I want to emphasize the magnitude of this outbreak is getting to the point that one has to anticipate that we're going to see spread outside of the outbreak area. And that's a direct result of the conflict blocking the ability for the public health response to take place.
That is truly scary. Well, this isn't in my notes, but after seeing that, will it get to the point where it will just because the hosts, I guess the folks that carry it would die, will it then decrease or will it just keep spreading?
The problem is that in the absence of effective public health response, you get a case, and then that case leads to multiple other cases. And you can see the curve is changing. It's no longer linear. It's starting to get an arch to it.
Yeah.
Whereas you see all those other cases, the curve plateaus, and then the outbreak stops, right? This is a direct result of not having the ability to operationalize what we know how to do. That is a public health response that we've outlined in our testimony, and it's blocked because of the insecurity in the area.
I'd like to follow up with one comment. That is the reality, and it's very sobering. All the more reason that our prevention initiatives in South Sudan, Burundi, Uganda, and Rwanda are scaled up, as Dr. Redfield said. Infection prevention, border security, airport security is very, very important. The fact that we are focusing and scaling up prevention in Goma, which is 120 miles south of this outbreak, is a critical part of the strategy. So to keep it from leaping the border and to keep it from going into Goma is part of this strategy, while the health responders are working day in and day out to continue to address what's happening in Butembo and Katwa and some of the other areas.
This next question might have already been answered, but I'd like a little clarification. The administration, how is there calibrating our response efforts in fiscal year 20 request, given the continued spread of the outbreak?
Congressman, I would say that that is being factored into the requests. We've just met recently with OMB. They know the requirements, and I'll keep you updated on how that goes.
Thank you, Admiral. I yield back the rest of my time, Chair Lady. Thank you.
Mr. Phillips?
Thank you, Madam Chair. My district, Minnesota's 3rd District, is home to one of the largest Liberian communities in the country, as you might know. And in 2014, 2015, of course, Ebola hit their country. And one of my extraordinary staffers in Minnesota, DeConti Sawyer, is a Liberian, and her husband, Patrick, is one of the very first Americans to actually die of Ebola. So I dedicate my questions today in his memory. And it is sometimes difficult to connect foreign affairs, of course, to dinner tables in America, but there is no question that if we don't help African nations stem the tide of Ebola, it surely will appear on our doorstep. So I'm grateful to both of you for the extraordinary work you do. I believe Chairwoman Bass asked some similar questions earlier, but my first question is about the distrust of international workers in the DRC. Some, of course, in the DRC believe that the Ebola outbreak was deliberately created and won't go to health facilities to seek care when they show symptoms. So what specifically, very specifically, relative to community engagement, education, is being done to educate and try to overcome that challenge?
As we look at this reset that we are supporting as part of the U.S. government, whole of government response, the focus on the community is specifically being targeted. In addition to engaging more effectively with the communities themselves, certain projects are being identified. Some WASH to do with increasing opportunities for them to earn, small projects in the community, be it infrastructure, be it wells, just to see if we can benefit and benefit them from small-scale infrastructure projects that will benefit the individuals as well as the community. Mm-hmm. That is step one. As we look at other opportunities to engage, it's going to be a challenge to continue to build, first of all, to understand, but then to build credibility so that the community itself can begin to own and collaborate with the health responders.
So, Admiral, if I can ask very specifically, though, so who are the gatekeepers in these communities, and how is information conveyed? Is it through, here it would be through social media. Is it through families and face-to-face? Is it through advertising? Is it through places of gathering? How do we try to communicate and overcome the disinformation?
Congressman, it's all of the above. Media, direct contact, face-to-face meetings. UNICEF is involved, CDC is involved with some of their community programs. Our partners are involved. That information is being collated and applied to improving community relations and building trust.
Okay. Doctor, anything you wish to add?
I think the complexity, Congressman, is that this is an area where distrust is really deep. Mm-hmm. You know, when we went there, we thought, well, maybe we could meet with the leaders. Right. Well, what leaders? Yeah. There's actually well over 100 different small rebel groups. It's one thing to deal with the ADF. You can find their leader and you can talk to them. But this Mahi is just a bunch of small groups with small leaders and disinformation going back and forth. So you get one group to have the right message, but then the other groups don't agree with the message because they don't trust that group. So it's going to be a long haul to get trust in that area. We reached out to the religious community to do it, the bishop, and again, they had a priest that was killed, and now the bishops are being intimidated. So this is a very, very complicated environment right now. And, how to really build trust in that community that's been at war for 25 years is going to be very complicated, and it's going to take a long time. That's one of the reasons we're concerned. This reset's critical. We got to get the community involved. We got to figure out something on the security side. Both of those are not easy answers, how we're going to get to either of them done.
And just a quick final question. Is the government in the DRC part of the problem or part of the solution?
Well, I can't comment. I'll go to the Admiral to comment. Now, historically, this is an area that doesn't trust their own government. Now, whether it's different with the new president, time will tell, but historically, they didn't trust their own government.
Admiral?
I would just concur with what Dr. Redfield said. This community feels abandoned, has been abandoned, and it's going to take a long time for them to trust the government. The good news is that we have a different government. It's in transition. It remains to be seen, once the cabinet is appointed, how they will appropriately respond.
If I
okay.
If I could just add, would you argue they might trust something from us, with the American brand on it as a source of information more than their own government right now relative to overcoming this?
It's pretty hard to speculate who they might trust. I would say they would trust their local representatives more than anybody else.
Okay.
I think I did mention earlier that President Tshisekedi did take a trip out. It was the first time the president had been in that area for years. Yeah. That's a step.
Good. All right. Thank you. I yield back.
In just a moment, I'm going to yield additional time to Mr. Smith, but before I do, I just want to ask a quick follow-up question to Dr. Redfield. It's my understanding that the World Health Organization has twice decided against declaring this outbreak as an international public health emergency, as it did for the Ebola epidemic in Liberia. First of all, is that correct?
Yes, Congresswoman.
And if the World Health Organization did declare this an international emergency, would it help to increase the production of vaccine or other measures that could be taken that would help to get this under control?
I think the WHO's made it clear. We were just at the World Health Assembly, and they've made direct requests that we need to stimulate more vaccine production. The decision to do an international significance is really a WHO decision, a committee decision. Historically, they've stayed to pretty strong guidelines that they do that when there's cross-border transmission. I will say that nothing about their decision to declare it or not declare it's impacting the United States' ability to respond. And it really basically is a consequence of their arbitrary guidelines that the committee has about calling it.
Okay. Thank you. With that, I yield additional time to Mr. Smith.
Thank you very much, Madam Chair. Admiral Ziemer, this is DRC's 10th outbreak of Ebola. Is there any evidence that anywhere else in DR Congo this hideous disease is manifesting? Let me also ask you, in your testimony, you talk about training some 1,680 community health workers to conduct surveillance, equipping them with knowledge and tools to gather information, to track the disease, and then you go on to say that we have trained nearly 3,000 healthcare workers in patient screening, isolation, appropriate waste management, and other practices to prevent disease transmission, as well as enhancing triage and isolation infrastructure. First of all, let me just say how grateful members of this committee I am certainly for that Herculean response. It is amazing. It needs to be, we are taking the lead, as we do so often, as we have in the past. So thank you for stepping up and doing it so robustly. That is a lot of training, and maybe you could explain a little bit what that training entails. But I want to thank you for that first and foremost, and you might want to speak a little bit further. And Dr. Redfield, you talk about CDC has designed the trainer's course for frontline response workers on tracing, contact tracing methods, and also that there's you've created an Ebola exposure window calculator smartphone app for case investigators. If you could provide us with some details on that. Again, we're talking about innovations, lessons learned. The title of your testimony, CDC, I think, is really responding very aggressively and very effectively as well. So I think the good news story for every American, they know their taxpayer dollars are being very aggressively being deployed in a way that's most likely to mitigate this terrible outbreak. And as you said, Dr. Redfield, this complicating factor of insecurity has so exacerbated what could have been maybe even stopped months ago. So I think, but thank you, great big thank you for that work. But if you could delve into some of those answers. I did ask earlier about the use of cell phones. Maybe you wanted to speak to that, because we know in Liberia and Sierra Leone that cell phone messages were everywhere about what to do, and that really helped get the message out, which helped to contain the contagion.
Let me start with your last question on the cell phones. I know the cell phone technology and use is being brought into many, many different development and health programs. How it's specifically being applied here in these two provinces, I'll have to get back to you on that. Okay. On the training, thanks. Usaid and the U.S. government recognizes the need for training at all levels, basic education, health training. When we look at the global health security agenda, we look at capacity building and health system strengthening. It is all about the investment in training the health care workers. So thanks for that recognition.
Thank you.
A couple comments to talk about what you brought out. I'm trying to read my note for the first one. I can't read my own writing. That's not so good. But
It's because you're a physician.
but I am a doctor. Okay, yeah, so I have some past. But I will start with the idea of communication. The challenge we have is not that people don't know that there's an Ebola outbreak. But I'm telling you, people who get sick with Ebola, a lot of them are deciding to stay home and hide. I told you 40% die. So it's not just them that are hiding, it's their family members are hiding. So this distrust issue is beyond knowledge. It's really pretty something when you know you're sick, you likely have Ebola, you know your wife has Ebola, and you know there's a health facility there, and you don't maybe trust it or not, and as I tell you, you basically stay home until you die. That's a big problem. So I think that's important. That's why I said it's going to take a long time. We're hopeful that we're going to get the word out, because there's now 4 experimental therapeutics that NIH is doing in a clinical trial there of promising therapeutics, that Ebola is not the same death sentence as it was in the West outbreak. But how can we start to get that information out to the community? It's actually an advantage for you to come forward and get treated, both in our ability to hydrate you properly, because we've learned how to do this better, and now that there's an opportunity to get some very new promising experimental therapeutics. So that's really a key issue to do. I will say on training, our field epidemiology training program, which we have now over in 70 countries, I said, in the DRC, it's our lifeline. We've got almost 200 individuals that have gone through what we call a 2-year epidemic investigator program like we have in the United States. When the Western outbreak happened in the early spring, when I first became CDC director, we were able to mobilize about 40 or 50 of those people along with CDC, and that outbreak shut down in less than 60 days. Now you got the Eastern outbreak. We were able to mobilize a lot of those individuals, but without the technical stewardship of the leadership of CDC to provide some ability to make sure what we said needed to be practiced is actually being practiced and reinforce it in the field, and as driven by the insecurity. We have started a center of excellence with the Minister of Health in Goma for Ebola. So we're trying to really enhance and accelerate training the trainers so that if we can't be in the field, at least we can be training the people that can go in the field and make sure we're increasing their skill sets more and more and more and more. And that is currently ongoing in Goma. Will continue. But I will say our overall concept here is we're not planning a 3-month strategy or a 6-month strategy. We need to dig in and realize that this is going to be a 12, 18, 24-month strategy, and then make the investment in those 12, 24-month interventions, like building the center to train people how to really do better at Ebola in the North Kivu province like we're doing in Goma.
Can I just ask you one final question? The 43 travelers that you mentioned per day that come to the United States from the DR Congo, and largely not the affected areas, as you indicate, how much of a risk is that? And not just to us, but also to neighboring African countries due to travel. How well screened are they before they hop on an airplane or use some other mode of transportation to
Right now, for the Congo, we do what we call level 2 screening. We have our ports of entries alerted. As you mentioned, these individuals are not from areas where there's active transmission at this point. That said, we're still alerted to be able to start looking at travelers that are coming from the DRC. As you mentioned, of the hundreds of thousands of travelers, we're very fortunate that not too many are coming from the Congo. I can tell you from the North Kivu region, it's probably almost reportable, in terms of having travelers from there. It's just not in an area that has travel is not part of their culture. But I think if we do get into Goma, that's going to change. If we do get into some other parts of the DRC, Kinshasa, that's going to change.
Again, thank you for your leadership. Thank you for the risk you take when you go there, and all the personnel that are deployed there from the United States and other places. But for those who do it, we all are very, very grateful. Yield back.
Ms. Houlihan, I understand you have additional questions.
I do, and thank you, Madam Chair. I just have had the opportunity on a different committee that I serve on to be doing a little bit more of a deep dive on the Mueller report on election interference, also on a task force that I'm participating on. And as a result of that deeper dive, I've had the opportunity to understand just how involved Russia was in the disinformation, misinformation with the AIDS outbreak in South Africa in the 80s, and deliberately sort of pointing the finger at the U.S. and our involvement or lack thereof in that particular outbreak. And so I guess my question to you is, as Russia and China are clearly rising on the continent of Africa and their influences clearly rising again in that particular area, have you any concern, have you seen anything that would indicate that there is any sort of campaign of disinformation against the United States specific about the rise of Ebola? Is that something that concerns you?
Thanks for the question. At this point, we haven't seen any indication that there's any direct strategy or intent to undermine the issue. But so that hasn't been an issue for trying to get the Ebola outbreak under control.
Are you concerned at all about that, given that the rise of Russia's strength, I think? In the 80s, they were significantly weakened, and that was a pretty weak attempt at disinformation. But do you have any concern that at this point in time it may become more strong?
I think the awareness is very high. I think the concern is there, and there are a number of agencies looking at that. The positioning, the influence of China is a priority. To any extent that it might be involving or undermining our ability to respond better to this outbreak, we'll get back to you on that.
Thank
but
you.
I don't sense it.
Thank you. I appreciate it. I yield back.
Mr. Phillips?
Thank you, Madam Chair. Doctor, on a scale from 1 to 10, how well prepared is the United States, God forbid, if we faced an Ebola outbreak or, for that matter, any other contagion on a national basis?
The domestic footprint for dealing with cross-border cases that would come in the United States is one of the great benefits of the 2014 is that we really have established a system. Multiple hospitals now across the country have been firmly prepared ahead of time how to do this in an effective way so we don't repeat some of the situations that happened in 2000. I think, as I said in my testimony, at present, the risk to our nation directly is extremely low just because of where this is. That may change if we get outbreaks if it spreads into Goma or into Kinshasa or into Kampala or something like that if this sort of dwells on. But we do have a very effective screening program now that we've developed in a sense as a consequence of that 2014 experience. So I do think we're very prepared here. This is why I come back and say, and I'll say to you in general for our health security, the best thing this nation can do to protect its health security is to detect, respond, and prevent these outbreaks where they start.
Agreed. Is there anything that you'd like to see us either provide resources for or improve strategically in the country?
Well, I think that, as we do these emergency responses from CDC's perspective, unlike, say, my colleagues at USAID, there are some things that would enable us to be more efficient, more effective, more timely. You know, particularly the ability to have direct hiring authority for these emergencies. USAID has that. We don't have that. Okay. Same thing in terms of our ability to procure different items that we need to procure so that we could have what we call other transactional authority, so that we can actually procure what we need when we need it. Okay. Those two things would be very helpful to CDC
for supplies and
for supplies, and not go out to a million different people to try to get competitive bidding when we need an emergency response. This would allow us to be much more effective, much more efficient in these responses, and it is something, as CDC director, we would like to see. We have that ability for these emergency responses.
All right. Thank you.
Yeah.
I yield back.
Last area. I guess I get the last word. Actually, you get the last word on this. I'm still highly concerned, and I think we all are, about the potential for travel to the United States. And I understand we're fortunate that at this point we have a low rate of travelers from the DRC, and that they are screened before they come here. But my understanding from, I think it was your written testimony, is that the incubation period can be as long as 21 days. So presumably somebody could be screened and not be showing any symptoms. Is that right?
They could be screened and not show symptoms at the time they're screened, but if they were from a high-risk area, then they would be put into a system to self-monitor for the development of a fever, similar to what we did in the 2014 outbreak, where the health departments will bring them into a system, let them self-monitor. If they do develop a symptom fever, then basically they would get laboratory diagnosis and then be handled appropriately.
That's dependent on accurate reporting, this self-monitoring system?
Yeah, I think the advantage we have, some of it's self-monitoring. The initial advantage is we do have the point of exit. So we know individuals that are coming from the exit. It's not like, for example, if we were dealing with Middle Eastern respiratory syncytial virus, where the real introduction might be someone shared a smoking lounge in London. Mm-hmm. Well, we wouldn't have any understanding of that. Here, at least, we know the areas that are at risk for their active transmission. Those individuals would be identified and screened as they came into this country, and then they would be set up with the health department. Depending on different health departments, would do it different ways, but most of the individuals do self-temperature assessment. They call them, do you have a temperature? Yes, no, and follow up there. I mean, it worked pretty effectively in the 2014 outbreak once it got operationalized.
Having said all of that, the need for containment is very much recognized by all of us here today. Yep. I'd like to thank both of you for your time on this very important subject, and also to everyone who attended this hearing, as well as the members who attended and asked very good questions. With that, this meeting is adjourned. Thank you.